Practicing medicine without insurance is possible. Imagine a private practice where you get to see your best patients every day, providing medical services you truly enjoy, all without the hassle of insurance. My name is Dr. T. Nguyen, and I'm a recovering specialist who was completely burned out from insurance-based medicine. I pivoted into direct care, where patients pay me directly for my medical services and have never looked back. If you're a private practice owner or planning to become one who's looking to be free of the grind of insurance and you're craving simplicity, efficiency, and connection with patients, you are in the right place. This podcast will help you map out your exit plan and uncover the mindset needed to thrive in today's economy. Welcome to the Direct Care Podcast for Specialists.
I have Dr. Jill Farmer, a nationally recognized neurologist, here with me today to talk about her direct specialty care practice. Welcome to the podcast.
Thanks so much for having me.
I noticed on your website it says, when a national expert becomes your neighborhood neurologist. And I feel like that encapsulates exactly what direct care is, what it does. And it's such a beautiful way to put the words together, and I wonder,
Thanks.
Is this something that you kind of came up with yourself?
I did. So my background is English. So I was an English major, and before I went into medical school, I worked in public relations at Scholastic Publishers. So I have a little bit of a background in marketing and communications, things like that. When I was at Scholastic Publishers, which is around the corner from New York University in New York City, it's in Soho, I decided to go back and pursue my prerequisites for medical school. So that's sort of my long, convoluted way of how I got into medicine. But I still love a good turn of phrase and a nice creative, marketing piece. So I came up with that and the name of my practice and the tagline for my practice, all of that.
Yeah, that's brilliant. So the reason why I loved it so much is because I think there's kind of a misconception about doctors who choose to opt out of insurance are some kind of reject, rebellious, like we just don't fit the common, like the status quo, right? I mean, that's exactly what we are. We don't fit the status quo. But that doesn't mean that we're not qualified, right? I think
Absolutely. Absolutely. Yeah, no, I was going to say, I think that going into direct specialty care was almost the opposite of that, was because I am an expert. I do have a lot of resources and education that I want to share with patients. I wasn't fitting into the mold. I wasn't able to practice the way that I wanted to practice in the restrictions that a insurance-based practice would allow me to do.
And I think the general public has an understanding, at least they're starting to move into understanding that a lot of the qualified doctors are leaving insurance and it makes them feel like perhaps they're getting abandoned. Have you had experience with patients did you take insurance before?
I did. And so I am a Parkinson specialist. So the vast majority of my patients are going to be Medicare dependent patients. And one of the ways that I felt comfortable in switching over to a direct specialty care practice was that I practiced in the same geographic area for about 10 years. So it was almost like I had a 10-year interview with these patients. And when I left to start my own practice and create this model, it was my hope that they felt that the care that they had gotten over that 10 years was worth paying out of pocket for. And I don't know if I would have felt as confident doing it, to be honest, if I was a new grad, like coming out and just trying to start my own practice. I think that might have been a harder sell. But having had a relationship with these patients and being able to explain to them my rationale, it was one of the ways that I think made it a slightly easier transition. That's not to say that there weren't a fair number of patients that just on principle were like, I have paid into Medicare my entire life. Like, I just can't do this. And I said, I completely understand that. And I helped them find another provider that was accepting insurance, was in their network, things like that. And I would say about a third of those patients that didn't necessarily come with me initially have since returned and said, oh, I see the value in what you provide. And I am happy to do this, especially when they realize, and I think this was a learning curve that I didn't even know that I had to provide, was that it's just the office visit. So many of my patients thought if I opted out of insurance, that meant that anything that I would prescribe for them, any lab test that I would order for them, any referral that I would make for them would not also be covered. And once I explained that and they realized that they really only see me about 3 times a year, the cost benefit analysis on their end was like, oh, this is well worth it.
That makes a lot of sense because I would have to agree when I was early in my transition, I didn't take the time to articulate that to patients because I didn't realize in their mind they thought that everything I would recommend would end
Yes.
up being out of pocket. So that I think that's really important to know if you're new to direct care, that you do have to explain to patients why it's a benefit to see you so that they can understand what they're paying into, but also give them the comfort or reassurance that if you were to recommend things, prescriptions, drugs, referrals,
Mhm.
those sorts of things, that it's actually covered.
Mhm. Yep. No, I think, and once I started explaining that, it definitely made the conversations that much easier. And like I said, I only came to that realization after a couple of conversations where patients were really concerned. And then when I kind of dug a little deeper and I understood what their concerns were, I realized that that part was an easy fix. Like I can reassure them that this is what they would still be able to use their insurance for and what they would not. And it seemed a lot less intimidating.
So you were in practice for 10 years before with insurance
Yes.
before you
Mhm.
decided to opt out. What actually made you like was there a turning point? Was there an incident?
Um,
What happened?
no, there was no specific incident. It was just sort of an itch. I had been with the same practice through different practice styles for 10 years. So when I graduated fellowship, I started at a hospital-based practice, and then this practice as a group moved into academic based practice. And then this practice as a group moved out of academics because the hospital we were affiliated with, Hahnemann Hospital in Philadelphia, closed. So everybody had to essentially scatter. And that then became a large subspecialty private practice, a neurology, neurosurgery mix. And so I had kept my practice and my patients afloat through these 3 different transitions. And I was starting to think, well, if I keep doing this and I've done it well, I'd kind of like to just do it for myself. And I got incredibly fortunate where my prior practice was supportive of this because I think they were looking to sort of change their focus and care to maybe be more focused on the neurosurgical side of things. So I wasn't met with that resistance or that stress. We have, you know, parted on very good terms, and it's not even parting. I still work with them and see patients through their practice a couple of times a month. So it was really amicable, which I know is not always the norm, but I was really lucky in that way.
So you got the support, you had an itch. Did you have a mentor to kind of show you what to expect as you
I
opted
did.
out?
So I'm the administrator of a large Facebook group called the Women's Neurology Group. And it's got women neurologists in the group from residency through retirement. And one of the physicians in that group, her name is Dr. Jennifer Wehrle. She's in Greenwich, Connecticut. She has been a big advocate for direct specialty care, and she did this herself 10 years ago. And she kept telling people like who were curious about it and wanting to learn more, she's like, it's really not that hard. When you opt out of insurance, you're able to have a much smaller footprint. You're able to have a much more manageable office structure and administrative structure where you can really be a one-woman show and make it work. And her encouragement and her consistent reinforcement that this was possible really kind of was the part that brought me over the finish line to actually do this. The other things that came to pass was there was an office space in my town where I live that became available. So I'm like, well, if I'm going to do this, I could move into this space and that would be worth it. So things were starting to align. My contract with my prior practice was coming to an end, and I said, now it just seems like the universe is telling me it's time. And then you were helpful as well when I was putting out questions to the Facebook world, like, what do I do for electronic medical records? How about prescribing? And you chimed in with your experiences, and I ended up using the simple practice and the I prescribe, and it's been really very, very easy.
Oh, I'm so happy because, I'm glad you bring this up because I'm part of a group as well, a podiatry specialty group, and there's a lot of us, a handful of us who talk about direct care. Oftentimes we get shut down. We get like the majority of people saying, don't talk about money. This is not the forum for that. That wasn't the question that was being asked. And it's like people want to shut us down when we are
Mm-hmm.
trying to share a brand new perspective. And so just hearing that you were able to get valuable resources from what I say, that's pretty wonderful. We
Absolutely.
all are entitled to our opinions, of course,
Of course. Yep.
but I feel like direct care is the most open-minded. I think it's because we've seen both sides and we're like, yeah, that's painful, but we don't have to
Mm-hmm.
continue to suffer. It's a choosing.
Yep. Mm-hmm.
So I'm checking out your website. You've got Simple Practice. You realize that they added a medication prescription option now? That's brand new.
I had it because I've just been kind of chugging along with my own thing, but I'll take a look at it and see.
Yeah,
Yeah.
I just learned about it. It took me a while to figure out. It's a little bit more expensive than the standalone I prescribe, but depending on your needs and your desire for convenience, you can do
Mm-hmm.
that directly through Simple Practice. And this is not an ad,
Yeah.
but it's a feature I actually wanted to talk about in a separate episode, but because I was actually looking for another platform because I was
Mm-hmm.
doing iPrescribe on my phone, and then I would have to get the e-fax and then have it uploaded to
Yeah.
the chart so that things are consistent, and it's just painful. Even
Mm-hmm.
though the volume of my practice is low, it's
Yeah.
still work. So
Mm-hmm.
just check that
Sure.
out,
Yeah.
see how that works
I
out for
will.
you.
Thank you.
You had transitioned into your direct care practice. How long has it been now?
A little over a year. So I left my last practice December of 23, and I kind of opened up mine February of 24. So we just celebrated our 1 year anniversary.
Congratulations. That's
Thank
got to
you.
be a huge milestone.
It is, and what has been even more reassuring for me is because my office space that I had found in my town is still under renovation. I pivoted a little bit, and I've been doing a lot of home visits and a lot of telemedicine. I'm a big advocate and proponent of telemedicine, particularly in my world of movement disorders. I find it incredibly helpful and very very utilitarian for both patient and doc. Um, and it's worked well. And the majority of my patients have been my follow-ups that have been part of my practice for 10 years. But over the year, word of mouth is a nice thing. And new patients have found me. And I haven't really had to do any advertising because I didn't want to explain the whole rationale for why I was doing home visits and telemedicine and didn't have a practice space and blah, blah, blah. And I was planning to open that up to advertising when the office opens, which will hopefully be by the end of the summer. But watching it kind of grow organically has been incredibly reassuring that it was a good decision. Like that I waiting and calculating and doing my research panned out, and it's been something that I've been very relieved by, because you take this leap and you don't know, and it is concerning, what's going to happen, but it's been working out okay.
This is a totally different trajectory than what I've experienced. And so I really enjoy hearing that you were already in your community for 10 years. So you
Mhm.
already created that rapport, that trust.
Mhm.
And you said that patients just ended up following you. So in your specialty, Parkinson's disease, you said that most of the people you see have Medicare. Is that correct?
Yes, that's correct. Mhm.
So did you expect that they would stay, or were you prepared to know that many will not stay?
I was prepared to know that many would not stay. And my price point was considered based on trying to be as enticing as possible. So I did not want to, make it too low to underscore and undercut anybody else in the area doing direct specialty care. But I also didn't necessarily follow a concierge model or things like that, where it's a large buy-in and there's some higher upfront cost. It's fee for service. So it's like I tell patients, like, think of your dentist or think of a psychiatrist or think like that. And I based it just a little bit above what the Medicare reimbursements are for new patient and follow-up visits, with a different pay structure for patients that do have out-of-network benefits and are able to get reimbursed. So basically, commercial insurance with out-of-network benefits is one fee for a follow-up and new visit, and anybody who can't submit for out-of-network benefits gets a 20% discount off of that fee. And I did that to, again, as a show of goodwill to my patients, to be like, I'm not trying to do this to price gouge you or to, rake in excessive funds or anything like that. I'm just trying to do this to have a smaller patient panel that will allow me to practice medicine the way I want to practice and give you the care that I want to give you so that you can be as successful as possible in managing this chronic neurodegenerative condition. And like I said, not everybody was on board. More people were than not. And they also realized that they only need to see me about 2 to 3 times a year. So it's not the expectation was that because I'll have this smaller patient panel, I'll be able to answer emails or have, a conversation on the phone or something like that without doing it begrudgingly, because I'm trying to add that in on top of a full day of patients. Like, I have the luxury of time where I can do that in between. So it saves them from having to see me, and it allows me to manage things much more gracefully than I would have had to do in my prior practice models.
This is interesting because I know another Parkinson's specialist and she has a membership model. And you're saying that
Mhm.
you have a fee for service model. How did you decide one direction or another?
So I don't like stress. And for me, the idea of a membership model made it so that I didn't want to feel like I was constantly on call. Like, I am essentially constantly on call, but the expectation is I don't have to call you back right away. Whereas for membership models, the expectation is like, as when I reach out, like, I'm going to get a return phone call. So I have the luxury of my outgoing voicemail message says that if messages come in for me after 3 p.m., like, expect that they will be returned the next business day or the day after. Like, I don't have that expectation of being on call 24/7. Like, on the weekends, I'm not going to reply unless it's like truly an emergency or something like that, where I feel that the membership models and the concierge models are a little bit more hands-on, more consistently. And that's not what I wanted for myself.
For those who are in neurology, are there certain specialties that you feel would be more fitting for direct care versus another?
I do. I definitely think things that have chronicity. So stuff for like neuroimmunology, like multiple sclerosis, or again, anything within the movement disorder world, Parkinson's disease, dystonias, ataxias, things like that. Um, for on a different model, like if it's not chronicity, but it is something like migraines, can be very nice for direct specialty care simply because they are procedure based, but those procedures, since most of those patients have commercial insurance, have the ability to still have their medications and things paid for through their specialty pharmacy benefits and patient copay assistance programs. So those also could be attractive as a direct specialty care model.
Has have you come across anything that surprised you along this first year in your direct specialty care practice?
So I do a fair amount of injections, whether it's for spasticity, for dystonia. I have inherited a few migraine patients from my prior practices, just because if you inject for one thing, you inject for all, kind of a thing. But I was pleasantly surprised that Medicare has a specialty pharmacy benefit. And some of my patients that I thought I'd have to give up injecting had a fairly reasonable copay for their toxin, and I was still able to inject them. I was expecting to have to give up all of my Medicare because in the insurance-based world, it's a buy and bill scenario, where you, as the provider, has to take on the onus of purchasing all the toxin, then submit and get reimbursed on the back end. But since Medicare does have a specialty pharmacy benefit, I don't have to do a buy and bill, and it is, again, taken care of by the patient's insurance.
I've not heard this term before, so I don't even understand what this means. So when you need the toxin, do you write the prescription and the patient picks it up and then you inject it? How does that look?
Yeah, it can go to the patient. Usually I have it shipped to me, but I will write the prescription. I will send it to a specialty pharmacy, like a Walgreens specialty pharmacy or a CVS specialty pharmacy, and they will work on getting approval and copay assistance if needed for the toxin. Whereas if you don't go that route, if you don't do it through a specialty pharmacy, then for someone who is on government insurance, whether it's Medicare, Medicaid, TRICARE, whatever it might be, you are responsible as the doctor for buying that toxin and then billing the insurance yourself to wait for the reimbursement on the back end.
So you're saying you would write the prescription to a specialty pharmacy. The pharmacy will
Yes,
process the insurance, whether it be a prior authorization or collect the copay. Then
correct.
the medicine gets sent to you, or does the
To
patient
me,
pick it
yep.
up?
The
It does get sent to
the
you.
medicine gets sent to me. Yes.
Okay, that's cool. That's really cool. I had no idea actually, so thank you for sharing that.
Yeah, no, it was something I learned on the way because I really didn't want to give up doing my injections. I really enjoy doing injections. I find them incredibly beneficial, incredibly therapeutic, and from a practicing point of view, they're fun to do. Like it's nice to do something hands-on to a patient that will give them benefit. And I was really happy. It doesn't work for everybody. There are some patients where the copay is either just too high or they don't have a specialty benefit that covers toxin. And then in that case, I, again, will happily refer them on to somebody who's in network because otherwise it's just too astronomical and it's not something that I would ever feel comfortable charging a patient to do.
How would you know if the patient has that benefit? Is it like a plan D or something?
Yeah, so that's where the specialty pharmacy comes into play. They
Okay,
will see and they'll let me know.
perfect. Because I was like, I can do less. I don't want to do more.
Yeah. Uh-huh.
Great. Has there been something that surprised you along this journey?
Again, I've been pleasantly surprised by the patients that are so supportive of it. Like you're asking patients to pay, and many of them in my world are on a fixed income or, Social Security and things like that. But when they encourage you and see the value and they say this is, especially when I do the home visits, when they say this is just unbelievable, uh, this is as much as we'd pay to go out to a nice dinner. Like it makes it feel like I am not doing something that is more of a hurdle. It's reinforcing that I'm doing something to try and bring care. And part of my process of actually taking the leap, I did have to come to terms to realize that I was self-selecting a certain population. I knew that I wasn't going to be able to continue to see everybody, and not everybody would be able to continue to see me. And that took me a while to get comfortable with. What I have also realized, and it's been pleasant, is if this continues to grow, then I will be able to incorporate some patients that either need a payment plan or that I need to offer charity care to or things like that. And I get to make those decisions because it's my practice. And again, I don't have to go through the hurdles of administration or bureaucracy of saying I can't see or have to refer somebody on to somebody else. If I choose to make the decision, then it's something I can do.
What do you think is the biggest challenge for somebody was in your situation, coming from an employed or insurance-based practice and wanting to start their own direct care practice?
I think the biggest challenge is to feel comfortable juggling many hats. Like you become the administrator, you become the marketer, you become the clinician. Uh, I like many hats. I like having I like it not being the same exact thing every single day. So that was appealing to me. But for somebody else, that might not be appealing. The other thing is be creative. And if you are concerned about revenue and, if you are the primary breadwinner of the family and this is going to be a big financial risk, look into making sure you have other revenue streams that can help supplement and support, whether that's consulting or working with pharmaceutical or industry or something like that. And again, that's something that might not be appealing to others, but for those that it is, it can be very rejuvenating and invigorating to feel like you're in control of the destiny of how you want to practice medicine and shape your practice.
If there's one thing you can change about your career trajectory into direct care, what would that be?
I wish I would have done it sooner. Yeah, I I really was not feeling compelled to, continue in medicine like after the pandemic and, dealing with so much of the culture of medicine that I felt was outside of my control. And, it really reinvigorated my enjoyment of the clinical practice. And I get that this isn't necessarily for everyone. I'm in a nice payer mix. I am not in a low cost of living or, a gentrified area. So I am well aware that this is something that is not going to be feasible for everybody. And I don't want to say that it's the panacea for all people who are disgruntled in their current practice. But if it is something that you're truly looking into, then do yourself the favor of at least exploring how it may be something that you could transition to or incorporate some principles into what you're doing.
So you like to wear a lot of hats, and so I imagine you like to do stuff outside of your clinic. Do you want to
I do.
share some of the things that you enjoy doing?
Sure. So I'm a big educator. I really, really enjoy doing patient education and provider education. So I am on the board for the New Jersey, Pennsylvania Parkinson's Foundation. I am on the board for Rock Steady Boxing International, which is an exercise regimen program for patients with Parkinson's disease. I do a fair amount of consulting with pharma, and I do education for nurse practitioners and physician's assistant through AMDAP, which is a new organization specifically for movement disorder nurse practitioner and physician assistants.
So being
Not
an
all of that is
entrepreneur
paid.
sounds.
So I was going to say, yeah. So not all of that is paid. So it's not like that's where I'm making like all of my money. The pharma consulting stuff is, but the rest of it is volunteer. And I wouldn't be able to do it if I didn't have the flexibility over my time and my schedule.
Yeah, and I think that's what a lot of us crave. It's just that I call it creative freedom, just the free will to do what
Yes,
we want to do. Well,
absolutely.
wonderful. Do you have any last words of advice or encouragement for the listeners?
Like I said, if this is something that you are toying with, I would try to seek out people who are in your specialty, who have done it before, and get as much information as you can, because it really is not as hard as you think. And there are ways to position yourself for it to be successful. So I would just encourage people to follow their dream of practicing medicine the way they want to practice.
So in case you guys missed two key points that was made about direct care, the first is do it sooner. And the second is it's not as hard as you might think it is. And I have to agree with those two things. Well, thank you so much for your time today. How can people contact you?
Thank you. So my website is www.BoroNeuro.com. That's BoroNeuro.com. That is, you can send an email or anything through that website, but if you did want to email me directly, you can email info, INFO, at BoroNeuro.com.
What is BoroNeuro? What does that mean?
So Borough is where the practice is in Hopewell Borough, New Jersey. And in town, there are things like Borough Bean and Borough Collision and Borough, like it's just sort of a prefix for some other businesses. And it rhymed with neuro. So that's why we liked BoroNeuro. My husband came up with that. But then I came up with, since it's in Hopewell, New Jersey, I came up with Move Well, Live Well, Hope Well.
That's perfect. I wish I lived in a town that rhymed with podiatry. But anyway.
That's a little harder, yeah.
Well, I thought podiatry by the sea, and I was like, I don't want to change my business name anymore. I'm over it. Well, thank you so much for your time. I so look forward to talking to you again and see how life progresses for you in your direct care
Yes.
practice in the next couple of years.
Anytime. Thank you so much for having me. This was fun.
If you enjoyed this episode, please give it a review and share it with a friend so more doctors can learn about direct care. Let's keep the conversation going on LinkedIn so we can help more doctors escape insurance and thrive in private practice. Thanks for listening. I'll talk with you next time. Take care.